As I said, welcome everyone to PPMD's webinar today on supporting families through decision making. My name is Alexis Hazlitt. I am Associate Vice President of Clinical Care. I am a nurse by training, and prior to joining PPMD, I was a nurse in the neuromuscular clinic at Children's Mercy Hospital in Kansas City. So the thought of palliative care and supporting families is near and dear to my heart, something that I worked very closely with when I was in clinic and hope to continue here at PPMD. I am joined by my colleague Patrick Motion, who will help co-moderate this session, and some wonderful panelists. So Patrick, if you want to go ahead and introduce yourself.
Sure. As Alexis said, my name is Patrick, and I am a person who lives with limb-girdle muscular dystrophy. I am in New Hampshire. I just turned almost 51 years old, and I am also involved with PPMD's Patient Adult Advisory Committee, also known as the PAC, which you'll meet a member of shortly. We are a group of almost 40 individuals living with Duchenne and Becker muscular dystrophy from around the United States, ages 18 all the way to 64, and we aim to elevate the patient voice in all that we do to make lives with muscular dystrophy as fulfilling and positive as possible. And one of the things that we want to get involved more in is normalizing the idea of palliative care. So that's what today's webinar is going to be all about. We're going to turn it over to the speakers in a moment here, and then later on we'll be able to do some questions and answers live on the webinar as well. And Alexis, I believe people can submit through the chat during the presentation also, or?
Yes, that is correct. So we'll have the speakers share their stories and experiences, and we have the chat open, so feel free to submit questions throughout the webinar, but at the end of the hour, we will open it up for Q&A and go through those questions at the end. So I don't know if we want to turn it over to our first speaker, Dr. Lauren Treat, who is a neurologist and palliative care physician at Children's Colorado. Dr. Treat.
Thanks so much, Alexis. What a great opportunity to be here with everyone today. I really feel like I should go last as far as the speakers, because really the people who have lived this journey are the ones that are the most important to hear from. But I think I was put first on this list because I just want to very early on in our discussion provide some basic information about palliative medicine. I think a lot of the focus for today will be on what it's like to step through this journey, especially at the decision-making time points, and how palliative medicine is perhaps uniquely valuable in those situations. And so I'd like to just spend a couple of minutes here speaking about what palliative medicine is. There's a huge amount of misunderstanding and misperception, both within medicine with the clinicians, as well as in the community with families and patients themselves. And so really important to get this cleared up early on in our discussion. So palliative medicine often gets associated with hospice, and that's where a lot of the fear and worry comes about. And so what I want you to hear loud and clear is that they are not the same thing. Palliative medicine is not equivalent to hospice. They are associated. Both really focus on quality of life. Palliative medicine is a much broader umbrella that focuses on quality of life at any point in a disease journey. For anyone who's living in a body that's complicated, I don't have to tell you that making choices between being healthy and feeling safe in your body sometimes can be in tension with times that you feel comfortable and get to do things the way that you want to do them. And so palliative medicine is uniquely kind of trained to recognize and call out those times, those tensions, and try to understand what a person's individual definition is of living well in their body, and then trying to match that up with the medical care that they receive. And so the big umbrella is about helping people with serious illness live as well as possible for as long as possible in their body. That can be at the time of diagnosis, start talking about the things that feel hard. That can be at any particular milestones along the way when there's changes in ambulation or changes in heart function or changes in other ways that your day-to-day life goes. Or it can be, very specific things that come up in the hospital about should we use a feeding tube or should we allow for a different kind of breathing support to be in place. The association with hospice is that hospice is kind of a very narrow section of that umbrella. So hospice is about quality of life, specifically at end of life. And so it's a philosophy, first and foremost, about how someone can, again, get as many good days as they can as time gets precious. And so that does live under that broad umbrella of palliative medicine, but it is not the same thing. When someone gets referred to palliative medicine, it's not going to be a conversation about hospice right away. And there is not any pressure when someone gets referred to palliative medicine to kind of move towards a comfort focus. Really, what palliative medicine's highest goal is to, just like Pat said, to amplify the voice of the individual themselves and help the medical team understand that to a greater degree, and then be able to talk openly about whether this medical treatment that's on the table is going to get you closer to or farther away from these things that you say are really, really important to you. So I think that's really, really important to understand. We very much acknowledge that the stigma exists and the misperceptions exist. And so we invite families to talk about that very early on in their visits with us, about saying, what have you heard about palliative medicine? What has been your prior experience? What's making you feel worried about even just coming to this clinic visit or to meeting with this team? It's important that we get all that out on the table so that we can address misperceptions and misunderstandings. In the kind of old model, when palliative medicine was first established, there was this sense of like, you're going to have one team to help with all of the treatment that's focused on disease modification. And then at some point, you're going to have to give up that team and switch over to a palliative medicine team. And so there was all this distress and angst about, have we done enough? Is it too early? Is it too late? What about all these feelings of abandonment that everyone's dealing with? And that was not a good model. We've moved away from that model towards a model where it's integrated, where palliative medicine can work alongside all the treating teams to be able to be there at various different steps in the way and ebb and flow back and forth and partner together so that families are feeling like they have the support to talk about what's important to them at every step of their journey. And so that their neurologists and rehab doctors and pulmonary doctors can focus a lot on their specific organ system and be able to say, you know, I am going to offer you the most robust plan that I can for your specific organ system. And we're also going to offer you this other team to be talking about to make sure that as we offer these treatments to you, they also match with your goals and your values and the way that you want to be supported in medicine. So I'll pause there, but I think that hopefully will help set the stage for some of the rest of our discussion about palliative medicine and its role alongside a muscle team.
Dr. Treat, thank you. And it is always good to see you again. I'll refrain from using a bad pun about how it's a treat to see. I couldn't refrain. I couldn't help myself. Alexis, before we move on, I see we do have a chat question coming in. This woman's experience that palliative care is not integrated in DMD clinics. I don't know if we want to wait a little bit on speaking to that till we get to our let's introduce our other speakers and stuff, but that is definitely something that is going to be brought up front and center. So let's go on. Susan, if you could tell us a little bit about yourself, and I am going to completely butcher your last name, even though I've known you for years, I still can't get it right. So I'll let you do yourself. Susan, how's things up in the Buffalo area?
Things are cold and wet. I'm not excited for the fall. My last name is Parzamiso. If you look at it slowly, it's just like it's written. I am a mother of a 15-year-old boy with Duchenne, Tommy. He has a twin sister, Megan, that I always like to bring her up, and she's important also to our experience with palliative care. Tommy was diagnosed with Duchenne when he was not quite 2 years old. So we've been living in this community for a very long time at this point. And to be honest, we were sailing along quite well for a very long time until about a year and a half ago when the bottom fell out. And I can tell you here in Western New York or in Buffalo, we don't have a local clinic. What we have are some very wonderful individual providers. But as far as our local care, it's something that I've been taking on and managing myself and coordinating. We do travel twice a year to Nationwide in Columbus, Ohio, and meet with the team there. And they've been very central to managing our care, especially since the past year and a half. At that time, Tommy has had a more mild presentation of Duchenne. He's still ambulating, but he does have advanced cardiac failure. A year and a half ago, he was diagnosed with moderate cardiac failure, and that brought a whole host of medical appointments and medications. And we're now seeing cardiology every 3 months between here at home and at Nationwide. Our pulmonologist here locally has also gotten very aggressive with Tommy's lung function to keep that as healthy as possible. So we're seeing them every 3 months. And over the past year, Tommy's skeletal muscles have really regressed big time. We're kind of on the fast track to non-ambulatory at this point. So in addition to all of the medical things with the cardiac issues, we've got, just in the past 3 months, we've gotten the power chair, the van. We're in the process of getting a lift from the garage and constructing a bathroom, all kinds of medical equipment in the house to help kind of keep us from falling too far behind the 8 ball and keeping up with his constantly changing ability to function. And that's been, as you all can imagine or have experienced with your son or a patient, it's very hard for Tommy at the time when he should be most independent. He's becoming the most dependent. And it's been very hard for his sister, who every new piece of equipment that's come in the house, she's kind of gone further down the rabbit hole of sadness, and just pushing down her emotions and not wanting to deal with her brother's changing condition. So and that's been affecting her ability to just enjoy life and do sports and do well in school. And we've been struggling with her in addition to the issues with our son, which is the obvious issue. I don't know, Pat, do you want me to go into my experience with palliative care at this point?
Yeah, I think just maybe giving us a little summary,
Yeah.
besides, the overall background and the fact that we all know, most of the people I assume on this webinar this afternoon, they're living with the condition like everyone on this call. So the unfortunate thing here is it's great that you share, as you say, the bottom falls out, every now and then. It seems worse than it things ebb and flow, and that's also a good time to be involved in the palliative care setting. So I think it would be a really nice bridge for you to talk a little bit about how that happened.
Yeah, and so I think probably everybody thought of palliative care as something that was only affiliated with hospice. And the first time it was mentioned to me in terms of Duchenne was we went to our clinic appointment last May in Columbus, and they have a whiteboard up in the clinic room that lists all the providers you're going to see. And for the first time, there was a palliative care at the bottom. And, after our diagnosis the year before, I was like, my stomach just went up into my throat. Like, what do these people know that they haven't told us yet? What are we in for in this clinic visit? And fortunately for us, there was no bad news. In fact, his heart had stabilized from the meds. So that was the good news. But we ran out of time before we could meet with the palliative care specialists there. But fortunately, back here at home, a Duchenne mom whose son is a few years older than us, I was talking with her, and she recommended palliative care because she had used them during the period of time when her son became non-ambulatory, and she recommended them to us. And so we're working with an agency that's affiliated with hospice, but they're a palliative care team. And they've been just such a blessing to us in helping me manage all that's going on. They help us. They have a 24/7 on-call pediatric nurses that I can call at any time with concerns about Tommy, and they can help me evaluate whether he needs emergency care or if it can wait till the morning, if it's overnight. The first thing they did was they reach out to doctors and help me reschedule appointments or fill prescriptions if the pharmacy is out of the medicine and I'm in a bind with that. They help. The first thing I had them do was when we first met, Tommy had an appointment with his endocrinologist coming up, and I hadn't gotten to the DEXA scan yet, and I had an 11-month-old prescription that I knew was no good. And locally, it's a chore and a challenge just to find a place that will do a pediatric DEXA scan, because we don't have a clinic environment. So they called the endocrinologist and they got me a new script, and they called around to find a place that could do the DEXA scan, and they even scheduled the appointment for me. So, you know, I've got their text number. I text them all the time, you know, can we reschedule this? Because as you can imagine, you've probably experienced, I get double and triple booked on days with all of these doctor's appointments, and it's just more than really I can manage. And they help me untangle all of this. In addition to all of the medical side, they've been very helpful with just kind of making our lives a little bit better. They've provided massage therapy for my son to help bridge the gap between physical therapy, because we get it through school. So there's always a gap at the end of the school year and at the beginning of the school year. And they have an art therapist on staff who specializes in sibling care. So my daughter gets to do art therapy that kind of forces her to bring up all of these emotions and deal with it. And it's been such an important tool to helping her improve her life. They are helping us find loaner equipment. We're in desperate need of a portable Hoyer lift. And I'm struggling with our Medicaid DME providers to get that. They've hunted down equipment loan closets and things like that to help us get the equipment that we need. So they've really just been a very holistic part of our care. And the other thing they do is they're hooked into the community that Tommy is very into sports. So they've helped me track down adaptive sports programs and fun things for him to do in addition to everything else. So they're really a wonderful part of our team. They come out, there's a nurse and a social worker that come out and meet with us on a monthly basis and check in and see what we need and see how they can help us. So it's been a very important part of our care.
Thank you for that, Susan. I think you used the perfect word when I think of palliative care is holistic, right? They're not just treating the diagnosis. They're not just caring for one portion of the child. They're caring for the whole family unit and your entire life, for mom, dad, siblings, the child, which I just think is such a huge service that, as we've mentioned, is not known, and there's a lot of stigma with it, which I know, Colin, you were going to speak on that. So I'll go ahead and turn it over to our next speaker, Colin Worth.
Thank you, Alexis, and glad to be here today. So I'm Colin Worth. I'm 28. You probably saw on the slide, I'm the president of PPMD's Adult Advisory Committee. So get to work with Pat over here. I guess I'd say I'm lucky to get to work with him. So I'm as I said, I'm 28. I live in Virginia. I currently receive care at VCU. I was actually at clinic today, and I think my doctors are listening in. So shout out to Dr. Amy Harper, and also my palliative care specialist, Dr. Dan Canoni. So so my experience with palliative care, fortunately, I didn't start seeing a palliative care provider until like 5 years ago, in my early 20s. So it wasn't until after my teenage years I think it would have been better to start earlier. And definitely is good, as we saw in the comments mentioned, to include it as part of the clinic as one of the providers you see. Definitely was I started seeing provider when I was at Duke, and that wasn't that was separate from the clinic. So I think definitely it should, as the other panelists have discussed, be included as part. And yeah, so I've been, I mean, really, I think it's good to emphasize that have the palliative care provider just to develop a relationship. Even I thankfully haven't been dealing with any major issues of late, but I think it's good to develop a relationship with your palliative care providers, so they know you, know your personality and preferences as far as what decisions in life, you know, everybody's different situation. And yeah, I think it's great, as Susan mentioned, that palliative care, I mean, should include not just the individual living with Duchenne, but the whole entire family, because it certainly affects everyone in the family. Yeah, especially parents, caregivers, and siblings. And yeah, I have a younger sister, and I know Pat has a sister too. So I definitely not forget and leave the siblings out. So yeah, again, glad to be here today, and I appreciate we're increasing awareness of palliative care and what it is, because as Dr. Treat mentioned, definitely a stigma out there. So hoping to break that stigma.
So, Colin, speaking of the stigma, I don't know if you saw this question, but it does say what are some big issues, and this could be Dr. Treat or Susan as well. What are some big issues that patients and families want to have addressed, but sometimes could be hesitant to bring up? Don't all jump in at once.
I don't know if it's a big issue that I want to have it. Well, I guess maybe it is. I know for years, ever since our diagnosis, I've always been asking questions of where can I find this resource, or how can I help my daughter? How can I find out about adaptive sports? And often I've been very unsatisfied with the lack of finding answers for these questions. And it was just so wonderful to have the palliative care team actually have knowledge, and if they didn't know, they did the digging and didn't tell me to go do the digging for it. I mean, I feel like for the first time I have my own personal assistant to help me with all of this, and so I think that's been just kind of overall all of the issues that I want to need help with. Palliative has been really excellent at helping me dig through and get answers to for the first time in years.
Yeah, I think one thing I would say, I guess, as part of that is definitely, I think the networking is a big aspect of the palliative care. Even I think it's been great for me to connect with others living with Duchenne and Becker through the PAC. That's great. That's a really good resource to know. You're not alone. Everyone's kind of going through the same thing at some point in their life. So yeah, I think that's a good resource to mention, to have yeah, other families network with each other, because yeah, it can be sometimes yeah, lonely, and you can get bogged down, but definitely it's good to be able to, yeah.
And Dr. Treat, please jump in here. But I know when I was in clinic, you know, a lot of families, it's not that they didn't have big issues or big questions, is they just didn't know what they didn't know. They didn't know that they could ask for palliative care to help with resources. They didn't know that they could have a supportive person help them through decision making. You know, when it comes to, do I choose a clinical trial? They're just turning to their neurologist to talk through that, not knowing that palliative care can help with that support as well. And so I'd love to hear your piece on that.
Great point, Alexis. Thank you so much. I think that's one of the most common refrains that I hear when people come to see me in clinic is like, where has this been? Why haven't we been talking about these things? And the honest answer to that is that the resources are still small. Palliative medicine doesn't exist everywhere. It's hard to get paid for in a lot of contexts. So making it be standard of care and having family and community voices say, hey, this is part of what constitutes high quality medical care. We need to be talking about these things. We need your voices as advocates to help make palliative medicine more available for people. But certainly people don't know what they don't know. That is certainly a piece of palliative medicine. And so as much as there's stigma getting in the way of people getting to a palliative medicine visit, both from just their own personal fears and worries, as well as their teams. Teams also hesitate to introduce palliative medicine because they don't want to worry people. They don't want to, have to talk about reasons why they're getting palliative medicine involved. And that's also a problem. We need to standardize this better so that there's less of that barrier to saying it's time for palliative care, just like Susan was talking about. Like seeing the name of that team on the board makes you think, is someone not telling me something, right? Do they know something I don't know? And why is this team getting involved? And if we could have it more systematic to say palliative medicine always sees our patients because it's just part of high quality care, for you to have a resource in this way, for you to feel supported in these conversations about being, who is the person that lives in this body, not just what does the body do, what is the lung function, what is the 5-minute walk test, what are these numbers, but who is the person that lives in that body. Certainly all of your doctors care about that, but it is the unique job of the palliative medicine team to dig into that a bit more and try to understand about what's getting in the way of living well on that level. And so this can range from a lot of different things, Alexis, to your question about what do people not know that they might be helped with from a palliative medicine team. A lot of it is just kind of creating an open space for people to be able to bring their full selves, that holistic view, their view about what is this like on an emotional level, on a psychological level, as well as a physical level, sometimes even like spiritual level, about what does it mean for me to live in a body that doesn't work the way that it was supposed to, especially in these times of adolescence and young adulthood, when the paradigm of what that time is supposed to look like is really different from what the lived experience can be for a lot of these young men. And so I think that there are just some really beautiful opportunities for families to have this kind of support. I will say that the support looks really different depending on where you're at. I'm so glad that Susan has this incredible, robust team in her local community, but even hospital to hospital and community to community. We say that if you've seen one palliative care team, you've seen one palliative care team, because they're not all alike. Some of the big themes are that hopefully they're going to provide, at least in the community resources do aim to provide that home-based care, the local resources to where someone is at, to get them a little bit more local connection to what's going on. The home-based teams also have that lens on family support to a greater degree, with siblings and parents, resources through social work, sometimes chaplaincy, things like that. The hospital-based teams are pretty variable as well in as far as who's involved in those. Sometimes it's just clinicians, like a nurse practitioner, often hopefully doctor as well, to be part of integrating those medical conversations. But often there's also a psychologist or child life specialist or something else that can help round out those pieces too. So lots of variability, but always this strong intention to see the person first in the context of the body that they're living in and in the context of the community as well.
So I think that's excellent. I want to back up actually before there's some more meaty questions in the chat, but I and some comments and some good networking going on. One of the things that I love about the webinars that we present at PPMD here too is there's always a sharing of current resources and even things to take a look at for other families that may be watching this later, because when it comes down to it, it really is all about connection and understanding. In this case, it's understanding about the palliative care. But I see, somebody put out something about the siblings. There's always, we're all on our islands all over the country here, and we always think we do a great job at connecting with different topics. But there's always something new to be learned. So I love all of you out there. If there's a piece of something that you think is related, even somewhat to this, please feel free to put it up in the chat if it's another reference or resource that has helped you. I do want to go all the way back to the beginning though, and Alexis, would you just speak to we obviously can speak more intelligently on our certified Duchenne care centers with PPMD, and how somebody put that, palliative is not always integrated in DMD clinics. Can you just speak briefly to the experience of when we certify what we require, but also, there are only mid-30s of CDCC clinics. There are going to be a good number of people around the country watching this that just don't have the means or are not close enough to a certified care center where palliative is, as I understand, a required part of the care. What can those families do to help educate their own local clinics that this is an important service that needs to be in the care model? And knowing that, we have a small elephant in the room here of that all the healthcare system also is supposed to make money, and palliative is on the same side of social work and doesn't always bring in a lot of dollars. So when we cut through all this red tape, we find out sometimes that the services that are being cut are the ones that maybe don't bring in a lot of money. So how would you also speak to the fact that there might be clinicians watching this now or later that don't have palliative in their center and they want to have it? How can the patient voice help support that? Because it is a needed part of care. How's that for you, Alexis? Did I just throw enough words at you at once?
Yeah, I think there's like 6 questions there. I will
Good.
start with the comment about how palliative care has not been integrated into certain DMD clinics that some of you all are attending. And I think that's something that PPMD has recognized. And when we worked on the certification or the guidelines for care for Duchenne care through the Lancet, we worked with the CDC to develop those guidelines. We made sure that palliative care was included in that as a part of standardized care for individuals with Duchenne and Becker. And our certified clinics are based off of those guidelines. And so when we look at clinics for certification, we make sure that palliative care is a part of their team and not just a part of the hospital, but that they have a relationship with the neuromuscular team. And that can look different in different clinics. Sometimes it's a referral. As Susan mentioned, those appointments are really long and you may not have time in the actual appointment day to get to palliative care. And so I know I can let Dr. Treat talk about her clinic model where she follows up afterwards with patients in a separate clinic, which is really nice. But that is something that, it's a model that we stand by. And I think the more that we talk about it, the more, it's going to get out there for other clinics too. And a lot of hospital systems do have palliative care as a part of their system, or they work with a hospice center who also has palliative medicine involved with it. And so trying to find those local centers, which might be difficult. I think someone else had asked, if you're not close to a certified clinic, how do you find those resources? And I don't know, Dr. Treat and Susan, if you want to speak to that of finding local palliative care.
Well, I can speak to me for locally. Our palliative care program, it's called Essential Care for Children, and they are affiliated through the hospice program here in Buffalo. And it was just I think that the other Duchenne mother gave me the contact information, but I think if you would just, Google hospice and give them a call, that would be a way to find the palliative care and just start talking with hospice because of that affiliation. But there wasn't anything more formal than that going on here.
Yeah, I'll jump into that, Susan. Thank you. So great clarification. A lot of the community agencies do live under the name of hospice. That's sometimes what you'll see most clearly, like on a Google Maps or a list of resources in your community. Many hospices, maybe most hospices, have an arm of their services that can be community palliative care. So they might list the community palliative care under their website as well. But if you're looking for community agencies, if you're not near a major medical center, it might be helpful to start your Google search with a hospice resource and then ask for their palliative care arm. Again, knowing that that's the bigger umbrella, because a lot of community agencies also have that umbrella. Not all, I don't think, but a lot of them do. So if you wanted to take that on your own, but I think the important point to emphasize here is that we need your voice. We need people to be asking for this. You deserve this support. It's meaningful support. Ask your medical teams, ask your community resources. The more that we hear from people that this is something that would be helpful to you and important to you, I think that's how we move the needle on this, to get people to pay attention, to say that this is meaningful and important. I use the analogy of a blood bank. Bear with me for just a minute, but if you were going to go get a surgery, you wouldn't really trust an operating room or a facility that didn't have a blood bank there, right? If they're going to cut me open, I need to know that they have a resource to support if things go sideways, right? To be able to give me blood in that situation. I feel like an analogy is similar to say, if we're going to do really high level advanced technology medical work, we need to have a resource that is there to help support the people in any, version of this that doesn't go exactly according to plan. And that's not just the purpose of palliative medicine, but it functions sort of in the same way, that if we're going to do gene therapies, if we're going to have people live on trachs and ventilators, if we're going to have people supported by a lot of intense stuff in their home, we owe it to them to also have this other resource. The blood bank on its own doesn't make money for the hospital, but it's there as part of high quality care in an operating room setting. And so similarly, if we're going to have a lot of this good medical care and these other ways that focuses so much on keeping the body alive and keeping the body going, we also need to have this other resource that helps support the person that lives in the body and the family that lives with them and cares for them. So I don't know if that translates or resonates with everyone, but I think it helps.
I think it's an excellent analogy, and I think it's something that a patient or a family can use when speaking to hospitals on their terms. Two quick other questions that have come through. One, is palliative in your purview, Susan and Dr. Treat? Is it usually covered by insurance? And is it necessary or highly recommended to find someone who's versed in Duchenne when looking for an agency?
I'll go first. I kind of remember giving them my health insurance information, but we have the Medicaid waiver for my son. So everything is covered, I assume, through Medicaid and through our private health insurance. There's nothing out of pocket for me whatsoever for the palliative care services. And I'm sorry, Pat, what was the second question?
Do you think again, the first one covered by insurance. Second, do you think it's necessary to find somebody that's versed in Duchenne Becker?
Yeah, our team isn't, and I don't think it was necessary, at least our experience so far. They've just been so wonderful at kind of being, we've talked about the umbrella. They kind of cover everything, and they're dealing with my family and where we are and what I need, regardless of this specific diagnosis. And they're dealing with things and helping me with things that aren't Duchenne specific, like managing my medical appointments or bringing in art therapy or calling for adaptive sports. Those aren't Duchenne specific things. So I don't think that's necessary.
Yeah, my experience in that is that, yes, palliative medicine should be covered by all insurances. There are a few important differences about care in pediatrics as compared to care in the adult side. Sometimes these can come up more towards the enrollment or the conversation around hospice. Sometimes there is some hard stops around insurance payments for both hospice and other kind of intense technologies or high-level technologies and specialists. But in the majority of cases, palliative medicine and all of your Duchenne's care should coexist and should get paid for by insurance. Always helpful to check your specific plans, but by and large, it's something that the insurance reimbursers actually recognize, again, as high quality care. They want you to be having conversations about whether that technology actually fits for you or works for you, rather than just going ahead and electing to have this procedure or that procedure. I would say, as far as the specialty level of care, there is I think there's definitely meaningful benefit to having someone who is well versed in Duchenne's care, but I wouldn't let someone who's not as familiar, I wouldn't let that be a barrier to plugging in with a palliative care team. There's a lot of common themes about just fragility, medical complexity that palliative care teams are very, very robust in handling and very comfortable with handling. And so I think that it should be able to be something that you still find meaningful, even if they're not directly linked to your Duchenne team.
On a related note, and maybe Colin may be able to weigh in on this, we had a question that was submitted before the webinar began about palliative care, possibly or not possibly reducing attendant care hours. Can any of you speak to that? Colin, do you know, or Dr. Treater, Susan, about if you have PCA hours and you have palliative coming in, will that tip the scale?
When I saw that question, I'll just jump in with what my experience has been. When I saw that question, it made me think that maybe either the people in the insurance realm or people in their hospital were making that really common mistake about confusing palliative care and hospice, because it is true for adults who are seeking hospice level of care, there has to be some conversation sometimes about what all is going to get covered. And that is an unfortunate reality of just the way that our insurance companies have set up the paradigm around hospice. But for palliative care, there should not be, again, this is theoretical, but there should not be any threat to your services. This should be a service that is in addition to and complementary to all of the medical care that you're already getting. And so again, sometimes you have to dig into why they're saying what they're saying, and are they confusing palliative medicine for hospice and trying to address that misconception. But from what I've seen, there has not been a threat to people's services just by having palliative medicine support, and there shouldn't be from a philosophical standpoint.
Excellent. Also, Colin, go ahead. Were you going to say something, buddy?
Yeah. Well, I was going to say, yeah, I guess I haven't really had experience with that, so I can't really comment on it.
So let me ask you, Colin, directly this question. I know you said it was a little bit later in your life that you got introduced to this. If you could rewind the clock, knowing what you know now, as a younger person, how would you start the conversation going to clinic, especially if the Duchenne Becker individual is a teenager, just kind of trying to adjust themselves to this life? How would you go about speaking to your parents or your clinical care providers about the fact that you want to see palliative? How would you start that conversation as someone that maybe is a little bit younger, looking back on what you know now?
Yeah, I definitely think, yeah, it's something I would wish I'd had known about, I guess. Really pointing to the providers clinics here, that definitely yeah, I think, like a lot, yeah, it's a lot of people have probably experienced or saw a few people in the comments too, that it's never been brought up. So I think just that should be regular part of the conversation at clinics. And I know yeah,
But so, I'm hearing you. I'm asking you how you would, for those people in the audience that might be kind of in this situation, how would you, as a Duchenne individual, how would you start the conversation?
Yeah, I mean, I guess I'm thinking, yeah, from my perspective, I mean, some people you would have realized the need for that, but not realize, yeah, I think just more education about palliative care, definitely, as we've all talked about the scare factor, thinking, oh, it's hospice, but definitely knowing, yeah, what palliative care. So I think awareness, and yeah, I mean, I know I'm not saying kind of answering the question, but I think the resources need to be put in there to know that you can ask that question.
Okay, and Susan, for you and your family, I mean, again, how would you suggest to families listening in today that they would even start the conversation without, dropping a hammer saying, I need palliative at this appointment 10 minutes ago, because that never works.
I mean, I think for me, it's just like help. I need help. It's more than I can handle with all of these changes that are going on. The talk was, when do you start? I think before about a year and a half ago, it may have been too much for me to add palliative care onto because we just didn't need that level of help. And I think I would have seen the monthly visits as more of a burden than a benefit. But since the last year and a half, with just the increase in so much of what we have to do and what I have to manage and how my family's dealing with it, I think just saying I need more help than I can find. I need, just guidance and just ask for help. And knowing that palliative care is a resource is huge. To be able to say I need help and do you have any palliative specialists is the best way to start.
Yeah. Okay. Colin, thank you for raising your hand. That's the way we like to. No, I'm just kidding. What's up, Colin? You have a thought? And then I have a question for Dr. Treat as well.
Yeah, I guess just coming from my perspective, I'm kind of a person that likes to be prepared. I think definitely should be emphasized that even though you may not need palliative care at the moment, it's definitely good to have a relationship there for when things do come crashing down. So you're prepared for that and have someone that knows you and knows what supports you need. So yeah, definitely important to emphasize that. But yeah, I realize, and even just introducing palliative care. I mean, we don't have to do it regularly or as often as weekly. Just like, I'm just seeing my provider, Dr. Canoni, every 6 months, and we're just just talk about how things are going, and if there's any concerns, definitely, can certainly talk to your provider more if needed, but I think just they're just even just checking in.
So
let's real quick, I was just going to add,
sorry.
For your clinic appointments too, those neuromuscular appointments, a lot of times a nurse or someone will call you before to confirm, ask what your needs are. At that point, if you've never met with palliative care or if you have a concern, you can ask, hey, can we add that to the list today? This is one of my priorities that I really want to focus on. Again, those appointments are very long, and so they can tell you, hey, you've got all these other people. Do you want to add them on at this clinic, or could we set up a separate appointment and you could meet with them at that time? And to your point, Colin, it doesn't have to be weekly or monthly. It can be just regular check-ins when you go in for your neuromuscular team. So I just always like to put a plug in that, you can always ask. And as you said, ask for help. That's what we're here for. That's what your clinical team is there for. And so really communicating that you want that service and that need, I think is going to help get the ball rolling. And obviously we have some work to do on our end with the clinicians of bringing it up earlier on so that it doesn't all fall to you. But I think between the two efforts, hopefully we can increase those conversations and connections.
I completely agree. And I wanted to just flip the script a little bit for Susan and Colin told us, their personal experiences with how to get in and the things they can do to help other families. But Dr. Treat, you see it from the other side of the perspective of the clinical ideas. What advice would you give to families about the best way to advocate and get this going for themselves when they feel the time is right to introduce this?
Yeah, thanks, Pat. I think one of the real strengths of Duchenne's models of care is that you have a little bit of anticipatory guidance about, what specialists are going to be involved at what different milestones or time points on the journey. And I think similarly, I would love to see my ideal version of this is that we include palliative medicine in that anticipatory guidance, that maybe you're introduced, maybe not to the specific team, but just the idea early on in the course of things that palliative medicine will be part of this team. And it's either going to come in at this milestone or this age. Sometimes it's around like specific things that happen if someone becomes non-ambulatory or if someone swallowing deteriorates and we're talking about different modes of feeding. for my clinic, the local Duchenne program here, we just normalize it at age 18. You know, I think it could be better suited to even be a little bit earlier because of all of those adolescent, you know, identity struggles and just trying to understand a little bit more of what the switch doesn't flip at 18, right? About you becoming an adult. Yes, sure, you get to make your own decisions, but there's a lot of lead up to that that's really important to try to empower the individual themselves to be taking control and feeling like they have agency and ability to kind of drive the boat, so to speak. And so I think standardizing it in some way is my preferred way to go about doing it. And then understanding that there's also flexibility, that if it feels like there's needs before that time comes up, whether those are because the stress and just worry component or the uncertainty, sometimes it's about what's happening to you, but sometimes it's about what you're observing about somebody else who's walking this journey, right? And trying to talk about what you've seen them go through and what, in reaction to what they're going through, you're feeling about your child's care or your own body. And so certainly knowing that there's flexibility in that model, but also knowing that there's going to be a standard of when palliative care is going to get introduced. That would be my preferred arrangement to all of this. And I find that it works really well in the clinic that I'm involved in, that standardization and saying, this is just what we do. This is part of good medical care here. And it takes that fear down a bit, right? For the clinicians as well as for the families to just say, this isn't, there's not many good surprises, right? In Duchenne's clinic. And so to eliminate one more surprise, to say that this is just time. We talked about this, we knew it was coming, and this is how it, you know, this is now part of it.
Can provide a comfort level. We do want to mention too that we have about 8 minutes. So if there are other clinicians, families, people on the call, there are quite a lot of participants. So please keep things coming in. But Alexis, I know you wanted to talk a little bit about balancing the family and privacy of the individual. Go ahead, Alexis.
Yeah, there was a question that came in that asked about how you balance working with the entire family and also talking to the teen and adult privately to understand their priorities and preferences. And so, Colin, I don't know if we could start with you and then maybe hear how Dr. Treat works with families, but have you found in your experience that your priorities and preferences may differ from your parents, and how have you navigated that with the palliative care team and having those conversations with or without your parents in the room?
Yeah, that's a good question. So, yeah, I guess as far as conversations in my family, we probably are definitely very open communication channels there. So definitely, yeah, not but yeah, afraid to bring up things, and definitely, yeah, get comfortable with, I mean, discussing important things with the parents in the room. Yeah, I'm definitely comfortable with that, but I know some might not always be comfortable with that. So definitely, yeah, not being afraid to ask providers, and I mean, have providers encourage patients to ask or talk to parents and say, maybe it might be a good time to step out, or even, yeah, I just think it's good to emphasize that, yeah, not to feel like you're pressured to have the parents in the room. And yeah, definitely being comfortable with speaking with providers in general. I mean, it comes with just getting older and independence wise. It's good to do that, speaking with providers. So yeah, not just for palliative care, but yeah, I know, yeah, I guess it definitely varies family by family, but definitely should be important to emphasize that option is there.
Yeah. And before we get to Dr. Treat, Susan, I'm curious, your experience, with Tommy being at age 15, that's right on the cusp of, starting to be available or able to start making decisions on his own and having those conversations alone with providers. What has your experience been?
As far as palliative care, it hasn't been an issue because they're working with me, and I'm still really almost 100% directing Tommy's care. He's, he does have his own psychologist that he works with, for issues like that. So it hasn't come up in the palliative care context for us, and we don't see them as part of our clinic appointments. So it's presented differently for us. It hasn't been an issue yet.
Colin?
Yeah, and I think it definitely, yeah, I know that's can be hard, especially or even recognizing that most teenagers, high schoolers definitely want that independence. Or not. I know parents definitely, from my perspective, parents are definitely caring and want the best decisions for their children, but definitely recognizing that they're their own person, and in the end it's their body, their decisions. So definitely there always is that pressure as parents to protect our kids, give what's best for them, but that may not always. Just respecting that difference is important.
I think that's a good point. With the couple of minutes we have left, Alexis, if it's okay with you, for Dr. Treat, Susan, and Colin, again, if maybe you could just summarize, or if there's one point that you would like families out there to know about palliative care that we haven't already covered, you'd like to make now. And we will not only make this webinar obviously available for people to watch later, but we're gonna do this more than once, because as we kind of take scope of the landscape, there's still a lot of people that are misunderstanding what this is as a service and what this is as part of the Duchenne and Becker journey. And that includes people that, are in the know. We have a lot of conversations with people that are very hooked into everything that's going on, and they're still unsure of what this actually is. So we have to keep continuing to get the word out. And for all the participants on the call, don't just be a passive participant. You have to activate your network now. If they don't know what's going on, start to educate. And we're here at PPMD to help you educate as well, with connections such as these on the call today, that I'm sure we'll be happy to connect with families after we get off the call. But with a couple of moments we have left, could you guys maybe summarize one more point that you'd like to get across about what palliative is, how it can help, and how we get the information more spread around? Maybe Dr. Treat, do you want to go first, since you're
Sure.
grinning and nodding your head?
I'll jump right into that. I just find that this is such a powerful way to talk about it with individual themselves who has experience, the parents who can also speak to their benefit, having palliative medicine involved in supporting them, and the siblings, and then also having the healthcare side of it. So thank you for bringing the panel together with these very, very essential voices all together. I think for me, the main message that I'd love to give is just that this is all about empowerment. This is about dignity and empowerment, and about allowing people to recognize what choice they do have in these really challenging circumstances. And that even includes choice about how you engage with your palliative team, at what frequency, and if it's, in close context with your neuromuscular visit, or if it's a week later, or some of these other things. So certainly there are constraints around what's available in your local area, but I would love to just convey loud and clear that it's about helping you figure out how you can show up as you to the best degree possible in the setting of some challenging things. And so that's what palliative medicine to me is really aimed to do, is to get to know the person first, and then to highlight those areas where we do have choice, and we do have the ability to make meaningful choices about how we live in the world, and how we try to navigate psychologically and physically some things that are really challenging.
Excellent. Colin, real quick, because I know Colin is a very busy guy. He's about to go interview a pharmaceutical company. Go, Colin.
So I think definitely wanted to say, I know some people probably or if they're needing even mental health counseling or need to see a psychologist, I guess definitely, I'm sure a lot of families there can relate to that. Not always, those providers may not always be familiar with like the complexity of dealing with a rare disease. So I think it's definitely where palliative care can step in and help, and familiar with dealing with complex medical issues. So again, just to realize palliative care is definitely an important step that should be added into care for DMD.
Thank you, Colin. Susan, last words?
I think just as a parent, knowing that palliative care is out there as an option and that it is not hospice, and even though it's maybe affiliated with hospice, we don't discuss anything even remotely related to hospice. And just knowing it's out there as a great option and one of the many tools available to us as Duchenne families to make our lives a little bit better.
Thank you.
Wonderful. Thank you all so much. Thank you to our wonderful panelists. Thank you to everybody who tuned in today. If you have questions after this webinar, please feel free to reach out to our care team at careteam@parentprojectmg.org, or you can schedule a one-to-one appointment with us through PPMD for You. We're happy to talk with you about your care team, where you can find a palliative care provider locally. We're happy to help support you in that. And then this webinar will be recorded and posted within the next week. So thank you again, and hope you all